Thank you for inviting me along to this webinar. As you've heard, my name is Borge and I am a lecturer in nursing at Glasgow Caledonian University. This short talk will have a discussion around evidence-based practice, and in particular it will focus around real-world evidence. So the example that I'm going to use when I'm speaking to you, and you'll see that a bit later on, is around case studies. And I'd also like to look at the context of where they fit in within the range of evidence that we have available to support our practice. Please note that this topic has been condensed into a bite-sized overview. A number of the themes and topics within here are taught over sometimes a couple of hours, sometimes days, and indeed sometimes entire modules at various levels within university education. So it is a bite-sized introduction, but hopefully that will give you some food for thought to start reading around and looking beyond some of those topics independently. So, when you're going on holiday, does your browser look a little bit like this? Mine certainly does. Really busy. I've got every single page open, every single flight page open, every hotel page, every single review page, scrolling through the results. So if your answer to this is yes, then we're already really singing from the same hymn sheet from the outset, really. Because what I'm doing here is, before I book my holiday, spend my hard-earned cash on a nice holiday, I've looked at the numerical data. So I've looked at the price of the flights. What value can I get there? What's the best class of flight that I can get for that money that I'm going to spend? What's the quickest way to get there? So a lot of numerical data. I'm also going to look at some qualitative data. So in particular around things such as how clean was the hotel? What did people think of the hotel? What are some reviews of the flights, etc.? What things are around the hotel? Looking at that big picture before I make that individual decision. So I've researched around making the best decision for me to have the best holiday at the best price and have the best time available. So if that is you as well, and it's not just around holidays, it's around lots of things, buying cars, buying anything new, buying a new washing machine, then actually you're really on a good road towards being able to find research, appraise research, and also find the best available evidence to provide the best available care to your patients. The first thing that we've got to understand here then is evidence-based practice. We've looked at it in a sort of day-to-day experience of something within our life, but actually when we look at it in the context of healthcare and the care that we provide in the context of, say, wound care, we've got to be able to think about it from a more evidenced, and we've got to look at some literature to support what we're saying. So what does the literature say? So this is a quote that I quite like explaining evidence-based practice because I think it encompasses a lot of elements. The important things to me here are around this collection and interpretation of data, and we'll cover a wee bit of that later. The fact that we're talking about things that are patient-reported, clinically observed, and research-focused. These are all really important. But actually, at the core of all that, within this definition, we also talk about the quality of clinical judgment and producing those outcomes for our patients, because we all want the best possible outcomes for our patients. So let's break evidence-based practice down a little bit more. So evidence-based practice is an amalgamation of research evidence. So what I like here is, in this diagram, is that it talks about the best available research evidence. And we'll unpick that a little bit later on in this talk. And that it doesn't just say research evidence, it talks about the best available, and there's a good reason for that. There's obviously patient preference and values. So if we then take that into context, our patients would sort of be secondary to what we're doing, but we know that they have to be at the heart of everything that we do. Clinical experience and expertise, we know that there's not always evidence for things. Through the COVID pandemic, quite often we were actually just phoning around and there was sharing of information where clinical experience and expertise was what we were working on a day-to-day basis. However, for evidence-based practice, we need an amalgamation of these things. The part of this that I'm going to focus on is around research. Now, most people, it will be healthcare practitioners, whatever field of practice that is, or whatever discipline that is, they'll have some understanding of research. So really, as a reminder of what research is, it's this process of an inquiry. It's systematic. What do we mean by it's systematic? It follows the research process. So I've not cited the research process within here, but just as a reminder of what the research process is, it's a systematic approach to investigating a problem, and asking a research question, reviewing literature, because that's really important that we review literature in the context of what we're asking, then designing a study. And we'll talk about study design because we're going to talk about case studies, and I suppose that reflects within there that collection of data, and then how we analyze it and then present it. So we often talk about dissemination of data. So that's what research is. Now, I've given 3 quotes here. Some of you will be familiar with them from sort of pre-registration education, but I think it gives a nice balanced view of what research is, and there's something there for everyone to understand depending on what way you think. So we've talked about this research, and we're kind of maybe flipping backwards a little bit here, where we talked about the research process, but that disseminated piece of research that we've got will then be graded within a hierarchy and the levels of evidence. So this hierarchy sits within this pyramid, and it's a simplified version, and I often use this because it's quite easy to understand that it has 5 levels. At the top of this is level 1 evidence. That's randomized controlled trials and your systematic reviews. So they're the highest level of evidence. We talk about them being high level evidence because they've got the least bias, they're transferable, and they're generally generalizable to a large population, and we'll understand why that is in a minute. However, as we go down the levels of evidence, you'll see that things such as case series, case studies, expert opinion are much lower down. But what I'd like to emphasize is that by the end of this talk, that they're no less important than any of the other evidence. We still need it within the context of our practice and what we do as healthcare practitioners. The Scottish Intercollegiate Guideline Network actually produce a more detailed version of this, and I quite like it. It's not sat in a pyramid anymore. They just explain it, and they have a little key so that you can see within their best practice guidelines what level each bit of evidence is that they cite. However, ignore that for a second, but I like the way that actually it breaks it up a little bit more. It pushes up these non-analytical studies, case studies, reports, and gives them some credit up there at number 3, which I really like, because actually we're really seeing the value of them. So just as a reminder, we do have 2 main research approaches. You'll be probably familiar with these, and that's quantitative and qualitative. Quantitative, where we're looking much more at scientific data, often concerned with numbers, numerical data. It's often analysed through computer statistics packages. It's deductive in its nature as it moves from what is known in the literature, and it tests applicability in other situations. We minimise variation, so we try and keep all the variables the same, apart from maybe one, or minimise them. And we can generalize it in that it's probably applicable to a large population with similar characteristics to those that are within the study. Qualitative, on the other side, is much more subjective. We are looking much more at descriptive elements here. We are gaining an understanding of a phenomena, of something that's going on. We interpret what's going on. So we maybe analyze interviews, we possibly analyze transcripts of interviews, of focus groups, just to give some example, case studies, etc. And we interpret that using themes, for example. These are just examples. There's lots of ways depending on methods used. However, we interpret these and we try to draw themes from that phenomenon. They do report a rich narrative. That's a real thing that I will demonstrate in a second. And it's really focused around the participants generally. And they're not always patients, bearing in mind that they can be clinicians, they can be a whole range of different people. And then bringing these together, don't forget, and it's out with the scope of this talk, we also have mixed methods where you use both approaches or a combination of approaches and combine them together to make good quality studies as well. So that's an overview of the two main approaches. We know about these approaches, and hopefully you're already thinking, in your context, so within wound care, can I always use level 1 evidence? Well, in short, the answer is no. So I'm going to give you an example from my practice. I recently conducted a study understanding student nurses' perceptions of caring for patients in clinical practice. Now, the word perceptions maybe gives it away here. Not every student will have experience of this. So I had to study perceptions. And for yourselves, that might even be relevant to yourselves. So how does this fit into the previous slides? Well, quite automatic, you probably are starting to think it is going to have to be qualitative data. Quantitative data probably here isn't going to give me very much. I can ask, do you have experience? Yes or no. Did you feel confident? And maybe put it on a scale. But actually, that's maybe as far as that goes for this study. What I want here is this rich narrative. So what I've provided here are some verbatim quotes from my study. I'm not going to read them all out individually, but if you do have a little read of them on your own, what you'll see is that there's some real food for thought there. And as a researcher, I kept my data collection around interviews that were semi-structured. I didn't have a rigid structure. It was quite free-flowing. I could ask a question and then take it wherever that participant was going with that information they were giving me. That gave that rich narrative of data, and actually I found things that I hadn't thought of, and that's really good in qualitative research. And this is about exploring real life. So going back to the topic of this webinar, about exploring real life here, so real life research and real life stories that can really fit into our research, or not fit into our research, but actually can give rich research findings. Let's think about this in relation to wound care. Within wound care, I'm no expert in wound care. I will hold my hands up. However, from having discussions, I'm very, very aware that actually it's very difficult to minimise variables among your patient groups. I'm pretty sure, especially the range of wounds that there are, and the context of where people are at the time when they have these wounds, the history, all these different things are variables that are really, really difficult for you to control. And so therefore, that makes randomized controlled trials very, very difficult. Sample size. Randomized controlled trials, so for quantitative data, you need massive sample sizes or very large sample sizes. For qualitative, the example of my study, my sample size is only 6 or 7, and that's completely fine for a study of that size. And you can actually have smaller depending. If anyone's looking into that, Brown and Clark have a textbook and about qualitative research, and actually has a nice table on sample sizes and illustrates that to you. The other thing is cost implications. To do randomized controlled trials, it's time consuming, it takes a lot of work, there's massive cost implications, and then on top of that you've got an evolving market of products available. That scientific development within wound care is taking leaps and bounds, and so therefore both of these things, by the time you get this randomized controlled trial going, it might be that the products that are available have improved no end, and making that not possible. Something that you will note is that best practice statements are available, and they will have randomized controlled trials, but they're not specific to any product. It's generally around leg ulcer healing, etc., for various other reasons that they'll have done randomized controls, as opposed to doing an actual product. So where do case studies fit into this? Now, if some of you read some of the textbooks, there is a little bit of controversy around case studies, and there are a number of other qualitative study designs. So, for example, within education, we use a thing called action research. And again, sample sizes are small, it's lived research, it's day-to-day research within the lived world, and it really feeds into and improves our practice as it can for you with case studies. So case studies is a used methodology, and case study methodology does exist and is documented within the texts. It usually focuses around individual patients, a person, so I'm saying person because not always patients, remember, groups of people or cohorts of people with specific characteristics. That data collection can be through a variety of methods. It can be through clinician observation. It can be through things such as, I suppose, focus groups, interviews with those individuals, or them getting to write their narrative, and I'll talk about that at the end. It does provide a rich narrative. You do get an abundance of data, and it does take a lot to decipher it and identify these themes. However, it's much easier to explore complex issues that you can't explore with what would probably be a superficial exploration using more quantitative methods. It can influence future studies. They're often very good as initial studies or being exploratory in their nature and guiding further studies that are more specific to certain things. I think, and if you read about them, patient narratives, as I've just mentioned, they can also be very useful within wound care. I have cited an article here, and it's around what is a case study. It's a very short article. It's 1.5 pages to 2 pages, and actually that's worth reading if you are interested in using case studies as part of research that you might do. Finally, not to forget quality improvement. Quality improvement is not research. However, bear in mind that case studies or the research that you do from these can then feed into quality improvement projects and actually improve practice that we have. Quality improvement is much easier to do on a small day-to-day basis. So bear in mind from your case studies that you collect, it might actually let you identify what change can we make here that will cause an improvement and take it through those cycles of improvement. So finally, here are some key references. There's a number of other references within there, but these are the key ones for the information rather than the diagrams, just to guide if you want to read any further. And thank you very much for listening.